All right, it just turned 7 o'clock, so I think we're going to start. First of all, I want to thank Opsen for putting this symposium in the morning to feed us great breakfast. And we're going to hear about the great case today. So it's my honor to share this podium with Jonathan Schwartz, Reda Ibrahim, and myself, Philippe Généreux. We're going to co-moderate and talk a little bit about the SavvyWire, which is a new tool from Opsen's Medical. And then we're going to share a little bit of our experience, the characteristic of the wire, and how the Sensor-Guided TAVI improve patient care. So I'm going to kick in with a brief introduction. Like I said, you're going to hear about Jonathan Schwartz, who's going to share his experience. Reda Ibrahim was intimately involved with the first in-human experience with the SavvyWire in Montreal. And myself with our center has embraced the SavvyWire as the default device, the wire for the TAVI. So, or my disclosure, here's going to have the three speaker. This is our best picture for the last 10 years that we took and put there. So I'm going to talk a little bit, give you an overview of the sensor guide solution with the sensor of OpSens with the SavvyWire. Jonathan will talk about the SavvyWire and how it facilitates lifetime management and case efficiency, especially with LV pacing. Something that is done frequently in Europe, and less frequent in US, but we're gaining momentum. And Reda Ibrahim from Montreal will talk about the importance of efficient hemodynamic assessment before and after procedure. And please feel free, after each talk, we're going to have some discussion. Feel free to ask questions. We need to be engaging. Just a few words about OpSens Medical. It's a French-Canadian company, actually, who has been very involved in sensor. Their key product is really an optical sensor, and there's multiple divisions. They're very famous. They are the one designing the sensor that is in every Impella. Very, very accurate sensor for the pressure that can last for more than 90 days in a patient, and the longest Impella has been implanted more than 1 year in a patient, and the sensor is still very robust with no change of signal. So this sensor has been built to last for months. So when you use it to do an FFR for 15 seconds, yes, it's going to be accurate with no drift. They also have a temperature sensor that they use in neurosurgery. They design their OptiWire for FFR. They call it DPR. And it's probably one of the best FFR wire for a tactile feedback point of view. And also, like I mentioned, very accurate, very robust. Can go in blood, in saline. You can connect, disconnect, and the zero will never change. So one of the best, more reliable sensor for coronaries. And then their new kids is the SavvyWire, where they leverage their Fidela sensor and they put it on the SavvyWire to design really the third generation TAVI wire, dedicated for TAVI, safer, good stiffness, but also capacity to LV pace, so insulation that allowed you to pace, and also sensor on the tip of the LV side to give you the gradient continuously during the case. They did more than 200,000 cases in coronaries and more than 2,000 SavvyWire already. So really a company based around sensor. So that's the device is the SavvyWire, and this is the console. You can see you have a wire with a console that can display, and you can put in your big screen also if you want, that display the pressure gradient before and after. And it's very useful and very convenient. So the SavvyWire, they like to call the 3P. First, performance. This is, like I said, a very good wire with good characteristic, very robust, and allow to deliver a valve in every type of anatomy. I did a lot of complex case with horizontal aorta, Evolute 34. It's very useful, very stable. Pressure, so like I said, leveraging their best sensor to get an accurate gradient reading, which is very important, especially when we go in valve, bicuspid, young patients. So it's very important to be accurate. And pacing, I think if you want to be efficient, move away from the RV pacing and pace reliably on the wire. This is one of the first LV wire to be approved by the FDA for dedicated LV pacing, where you don't have to scrape the coating, etc. So that's the beast. You see this wire, so typical pre-shaped wire for TAVR 035, exchange length for 280, a little bit longer than usual, so allow you to exchange, put the device on and still have a place to connect. It's like the FFR wire, the connector. You connect the distal end in the captor, so you can connect in the connector, and you can connect and have the pressure. It's a very nice color, orange. It's insulated with PTFE sleeve, which allow for great conduction for the pacing. At the tip, you can see here, there's in the LV side, there's a sensor, which allow you to have the LV pressure. And this is the tip, the pigtail tip, where you can pace with the entire tip of the wire. And when you pace, when you do the case, you can connect your alligator clip either at the tip, distal tip, or there's a pacing zone when the device is in, when you can clip more proximal in front of you. So that's the description of the device. There's two sizes, small or extra small. Most of the time, I would say 90% we use the extra small, and for large ventricle, EF low, 20%, we use the small. This is what you have when you have this. When you connect and you have the pressure, you can, like I said, you can sleeve that on the big screen, or you can have the display, the usual console, and you can see the pressure, the systolic, diastolic, LVDP, which could be useful, the gradient, and you can choose mean gradient, peak to peak. You have the heart rate, and you can export this to DICOM and USB. You also have in Canada, the ARI index and all the derivative to assess aortic regurgitation. This is some of cases. I think we did more than 200 SavvyWire cases in Morristown. We use all the type of valve. We use it with Portico, with Navitor, with Sapien, with Evolute, valve-in-valve, bicuspid. We did everything. And it's I really like the stiffness of the wire, especially for valve-in-valve and Evolute 34. You can really push well on the device, on the wire safely, and also the device to be on a greater curvature. Still can pace with the big pigtail while you're pulling the wire, and really a good for self-expandable, good wire for self-expandable. This is one of the cases of Reda Ibrahim, one of the first case performed very good trackability, and really good central position. So it's really a standard wire, but that has been refined a little bit to have more stiffness in the ascending arch. And good stiffness also in the descending arch. So this is a case of Reda, actually one of the first. That was part of the launch, and give a little bit of a chill to the company because he wanted to do a very tough case with the axillary access. And you can see very good traction, very difficult and tight traction, but the wire behaved very well and allowed the completion of the case, the successful completion of the case. And this is the case. I suspect it was a low flow, low gradient patient, but had a very good result after. And you can see here that this is the sensor of the pressure. This is the pacing zone with a big pigtail ball. This is a case that's been done with no venous access and with very good result in efficiency. We did a companion analysis, so we were a little bit sad not to be part of the launch in Canada. So we decided to do in Morristown a study using the OptiWire with the same console, the same algorithm, where we did 20 TAVI patients, where I did the assessment with 2 pigtail before the TAVR, a TT and a TE. We record the gradient with all the modality and with the OptiWire using the same sensing and the same algorithm, and we compare the gradient before and after with all those modality. And what we saw actually is the OpSense, okay, the Savvy algorithm to detect gradient was almost identical to the 2 pigtail gradient, so either pre or post. So it's very reassuring, a good, strong correlation with the 2 pigtail, and probably meaning that you don't need the 2 pigtail to equalize, to exchange, and if you have a wire already in the LV, you can just connect and you have your gradient. In conclusion, this is one, I really like this wire because this is a very strong innovation in the field of TAVR. where you can have a good wire to implant the valve with different stiffness, which is more customized to or specific to our TAVR these days, with accurate hemodynamic assessment immediately during and after the case. Some also AI metrics that will be coming soon in US, which is very exciting, and pacing on the wire to improve efficiency and flow of the cases. So we have embraced this technology at Morristown. It cuts a lot of time during the TAVR. I would say 25%. You don't have to put a venous line, and you're going to hear more from Jonathan and from Reda sharing this experience. So thank you for your attention, and if you have any questions, please feel free. Now I'm going to invite Jonathan, if you want to start, and then we can have questions after you show your case.
Sure.
So Jonathan will talk about the case efficiency and the LV pacing.
Great, thank you, Philippe. Thank you also to OpSens and to all of you for being here. It's an honor to talk a little bit about the SavvyWire today. So disclosures here. So my task here is just to kind of go through a little bit of the procedural aspects of it, as well as talk about some data, and then we have a couple cases to talk about too. So the SavvyWire, sort of as we just heard, it's on label, a unipolar left ventricular pacing. It has a built-in shaft with insulation that allows for pacing at any time without an extra catheter. And then it also eliminates the RV access if you don't feel like you need it. I know sometimes anesthesia is asking for venous access just for help, but you would not have to put a pacer in, and that sort of can decrease your risk of potential pericardial effusion from your RV pacing wire. The display is quite nice, as you've seen some pictures of it here. Very easy to see from any point of the room with immediate pressure measurements, and then a nice little summary screen, which we'll look at a little bit later. So the actual pacing part of the procedure, not too difficult. I do think it's a little bit easier than the way that we've been sort of doing it off-label, where you have to scrape the wire and make a little incision and put the electrodes in the skin of the patient. So for this one, you make sure that your guide wire is placed in the LV cavity in contact with the myocardium. I know when we're using like Safari wires or whatever your favorite wire is, you sort of have to make sure you really bury the wire. That's less important here just because you're pacing at any point along that curl. So as long as it's in the LV and you can tell that there is some contact with the myocardium, you don't have to really push it in, which is, again, some of these patients have quite frail tissue, and you don't want to be pushing things too much if you don't have to. Then you use an alligator clip that is attached to the subcutaneous tissue that act as a grounding needle. Usually what we do is just put like a micropuncture needle into the skin, and then you just attach right to the needle itself, so you don't have to make any extra cuts or anything into the skin. The other clip then, which as acting as your cathode, you attach to the back part of the wire on the denuded part, which is very obvious to see since the wire is coated with an orange coating, and this part is not coated, so it's not too hard. There's also a secondary place you can connect a little bit further down if it works better for the ergonomics of your setup for your case. Then you connect the electric cable with the pulse generator on the backside and test capture at different voltages. This is very similar to what you do already with your RV pacing. You just sort of dial it down like usual. It should be no different than the procedure for anesthesia, so pretty simple there. So then, after you get all that set up, you can insert your valve delivery system over your SavvyWire, and then you reconnect on the backside and connect your black alligator clip to the uninsulated portion. You keep a little bit of forward pressure just to make sure that it's still in contact, and then you can rapid or control pace depending on what type of valve you're using here. Usually we do it at max output. I still like to sort of know where your drop-off is, but just to be safe, you don't want to lose capture during your case. So if it goes up to 25, I've done as low as 10 before, and that's worked as well. So there should be no concern about the output there. So any level where you can guarantee you're going to have capture should be fine. Then you observe that the SavvyWire is positioned in the apex. You maintain some forward wire position. Keep it in contact with the LV wall while you're doing it. And then the squeeze of the SavvyWire will show adequate contact during your pacing here. So just your output is very similar to what you see and what you're used to with your RV pacing. You can see at the bottom there. You can really pace at any rate here, 60 to 80, just to sort of pace a controlled rate. Like let's say if you have heart block afterwards, it's safe to use it for that, and then if you're going to put like a more durable solution and to send them to either to the ICU or to the floor afterwards, it's safe to pace at that rate. Sometimes for your self-expandable valves, you're going to go a little bit higher than that. Again, usually there's no issues with capture there as well, and then for rapid pacing for your balloon expandable valves, there's no problems there as well. The highest output, like we just mentioned, is recommended, but just make sure you test it and find out where your capture level is lost. And your sensitivity, it's recommended to be asynchronous while you're using this. So looking at the data here, they've done some nice studies here. So the EASY TAVR trial was a prospective multicenter single-blinded superiority randomized control trial looking at whether LV pacing with the guide wire reduced the procedure duration while also maintaining efficacy and safety. There were 151 patients enrolled in the LV pacing and 152 in the RV pacing. This was all done in France. You can see the results here. Very nice. Procedural success was great. There were no significant difference in adverse events. Tamponade was about the same also, bleeding, all those issues, no problems. The procedure time, though, you can see was significantly shortened by almost 10 minutes with your LV pacing compared to RV pacing. Fluoro time was a little bit less since you're not having to navigate through the veins to get to the RV anymore, and the cost was actually a little bit lower as well, which is a nice thing to see there. Then another trial, at Erasmus, the lean TAVI study. This was just an observational registry, but still some good data came out of it. The patients received pacing on the wire when necessary, and unless there was some risk of needing more support based on their conduction, and then follow-up was at 30 days. Looking at the safety and the feasibility of restrictive temporary RV pacemaker use and evaluating the need for pacer after failed LV pacing ability without capture or any occurrence of AV block during pacing. Much bigger study here, 672 patients, and you can see here the procedural characteristics, really no problems in terms of needing with valve embolization or the heart block you could see was actually a little bit lower with patients that had LV pacing. Same thing, about the same rate with new left bundle branch block, but a little bit lower there. And then the temporary pacer was left less often when you did the LV pacing. More significant here, kind of the focus was the 30-day results here. The LV pacing had a lower neurological event rate. The LV new left bundle branch block rate was lower. Pacemaker rate was lower. The length of stay was about a day or two shorter, and your rehospitalization rate was also shorter. So great to see that as well. The first in human study was done with 20 patients looking at asymptomatic AS. This was done in Quebec. Reda played a role in this, so maybe you can give us some comments afterwards if you like. But and looking for safety to make sure there's no complications, and then the efficacy of the pacing during the cases. So no problems with rapid pacing capture failure, which was great. That's also been my experience so far, and obviously not in a clinical trial setting, but I've had no issues with losing capture, and then the valve was implanted in all 20 patients, which was great. So that's great for some data. You do have some evidence that this works well. Let's just go through a couple cases now. These are both my cases here. So the first one, an 87-year-old woman, multiple comorbidities, obviously has severe AS. That's the whole point of that we're doing this. Had some typical symptoms coming in with progressive dyspnea on exertion, referred for consideration of TAVR, but despite being 87, still had a good quality of life. We did the whole workup and then was obviously felt to be a good candidate for TAVR at that age. You can see here very, very stiff leaflets, no issues, with a gradient of 40 on her pre-procedure echo. CT with the sizing here, relatively small valve here. Access did not appear to be any no problems at all. So the plan was to put in a S3 Ultra, 20 millimeters, going with the right femoral access without needing a BAV. There was no significant heavy calcification there. So. And then we wanted to use the OpSense wire. This was one of our very early cases, and so just I thought it might be useful to show. I did put a temporary venous pacer wire just in case, but we did not have to use it at all. So you'll see it here. So the valve deployment was very no issues, very straightforward. Pacing, we had no problems at all, both with the capture and during the case. You can see the pre-gradient. For this one, she was under sedation, so it did measure as 30, which was a little bit less than the pre-procedure, but I think that was more likely just due to the sedation. After the valve was deployed, you can see the mean gradient was down to 1, which was great, and then the surface echo immediately at bedside showed a gradient of 6. So great result there. The pacing worked great. We had immediate pressure measurements, and then at the end of the case, you get sort of a nice little summary screen here and shows your difference in your pressure, and you can see the systolic pressure also came up after the procedure. So she did very well. We had no problems there. Next case, very similar. And this was an 89-year-old woman. Again, multiple comorbidities. Her gradient was a little bit lower, but she did have progressive dyspnea on exertion. And we did feel that her symptoms were likely related to her aortic stenosis. So was referred for this. The family was involved in her care, but she still, again, had a good quality of life, so we thought she would benefit from getting a TAVR. The workup was pursued, and then TAVR was chosen as the best choice. Not great pictures here, which made for some difficult pressure measurements across her aortic valve. Another great reason why we got some definitely more accurate measurements with the SavvyWire here. But you can see her pre-gradient was around 39 or so. Measurements here, a little bit larger than the prior case. No access issues, just a little bit of calcium there, so didn't anticipate any problems. So the plan was to proceed with a SAPIEN 3 Ultra, number 23, again with right femoral access, no BAV. This patient actually had a permanent pacemaker, but I thought, since we have the SavvyWire option here, why don't we use that for pacing instead? It meant that we didn't have to have a rep in the room, so that saved us a little bit of time as well. So the case, again, deployment, very straightforward, no problems, both with capture and during the procedure. The patient pacing had great capture. We didn't have any skipped beats or any issues that we were concerned about. This one, again, she was sedated, and so the pressure was a little bit lower than her pre-procedure echo, but measured at 25, and then after the valve was deployed, was down to 0, which was great, and then the bedside echo showed a gradient of about 8 or so. So again, nice, a little summary scheme here. Difference in pressure from 25 down to 2, significant increase in her systolic pressure right after, and she felt much, much better even just in the recovery area, which was great. So I was able to get through that case without any issues. So in summary, we've shown here a couple cases and some data. The LV pacing with the SavvyWire, it's safe and effective. It's very easy to learn. It fits in the workflow, very similar to what you're likely already using if you're using RV pacing. It takes less time, saves you an access site. It offers immediate and accurate real-time LV pressure measurements, so there's certain cases where that's particularly helpful, but it also is nice just to see that you are making a difference, and you can see that if there's any signs of issues, it's immediately available as soon as the valve is deployed. And you can safely use this for a large majority of patients, which is great. Thank you.
Thank you so much, Jonathan. So maybe we're going to stop here and have a little discussion about the LV pacing. So before the SavvyWire, I was only RV pacing, and I don't know why. I think it was more as an habit. Get trained like that, and we're doing it. And there were no, I would say, dedicated or approved device to do this. So, but in Europe, everybody's pacing on the left wire since a long time. And so, tell me about your transition, or since when did you start to use LV? Because we all train in US with RV, and then how was it for you?
Yeah, so for us, I think around the time that it's sort of, you started hearing about it from Europe, we usually use the SavvyWire. We didn't love it. I think when you have to scrape off part of the coating, and we've had a few cases where during the testing to make sure we were capturing, it wasn't always working, and then you don't know, is it because did you not scrape enough? Is it not buried enough? It just was very unreliable, and so we didn't find it useful, and so we just kind of went back to the usual RV pacing. It wasn't that long ago that we started using SavvyWire. None of those issues came up, so it made it a lot easier.
Mm-hmm. And when you look at a threshold, it's funny because when you do the scraping wire and you try, it's always like around 10. Okay, you lose this. So I start to test the SavvyWire, and sometimes it's 2, 5. So we always crank it up at 25 anyway. But the insulation and the way Sebastian, the lead engineer, designed the wire make a big difference. You hear the comments, is it unipolar, bipolar? So this is a unipolar wire, you need to ground it. But the difference is very minimal between unipolar and bipolar. So, and there's manuscript out there that show that there is no real difference in capture. So I think if you test the sensing before you have the device, the catheter on, and you test, it's going to be like 2 or 3 threshold, and which is very enough. I would say that the technique of the LV pacing is crucial. For me, you need to have control of everything, much more. We never hold the RV pacing. When you RV pace, you see this jumping sometime, but with this, you have the control of, you hold the wire with your right hand in position, like a good rail, and with your left hands, you have the device, the sheet, and your 2 first finger, and you kind of push a little with the device, you kind of hold the device and the system in place. So even if you have a skip bead, if you have your hands on the wire and the device, everything is stable. It's not going to jump. If you're like that and you watch, yes, but if you have a good rail and a forward pressure a little bit on the system, everything will stay in place. So, Reda, I don't know what is your take on LV pacing and your...
No, I think there's nothing missing here, to be honest, Philippe. Here we have evidence, we have data published that the LV pacing is as good as or even better than RV pacing. We want also to be efficient in the cath lab, so we want to do more case. I mean, there's no doubt in my mind that it's longer to put an RV pacing lead. We all had difficult cases just to bring the pacemaker lead in the ventricle. So often the vein are hostile, very tortuous. So I think we are saving time on that aspect. We have the evidence, and I think it's better to pace directly in the LV than to pace in the RV and it's better to pace directly and to decrease directly the pressure within the ventricle than to wait to transmit the pacing from the RV to the LV. So I think there's nothing missing. For pacing.
Yeah, I also think it's nice because sometimes there's a little bit of a hurdle to get over with your lab staff when you're bringing in new equipment and trying to train them. This pretty much already fits into your workflow, like you said, with the pressure on the wire. You're doing that anyway, even if you're not pacing with this wire. So that part's not too hard. The connection at the back, most likely the lab is very familiar with that, with all the FFR wires that we use. So the same thing with anesthesia. The pacing is the same from their standpoint. So it's really not that hard to sort of.
And we all experience tamponade after RV pacing removal. I mean, it's frustrating. You do a nice TAVI procedure, and then you remove your pacemaker lead from the RV and then tamponade. It's just frustrating. I mean.
Yeah. Itzik, we have a question.
Hi, thank you. So I have a question. You need to equalize the wire before you go in, correct?
All right, so that's Reda will talk about that, but let's address your question. But yeah, so there's.
But then when you finish, you cannot get the gradient immediately. You need to pull back the wire, not outside, but pull it back almost. You can lose the wire to equalize again to get the final gradient.
No, we kind of streamline the way, and Reda will talk about that. So the way to do this, there's multiple ways, because yes, you need to equalize the LV pacer, the LV sensor, and the pressure, right? So the way we did, when you connect your wire, you bring your wire, you put in the LV, okay? Most of the time, it's already, you zero your assist, right, or whatever your pressure that you inject to the pigtail, and you have your sensor in the LV. You take the gradient. I don't equalize. I just look at the gradient. Most of the time, it's very accurate. And then you do the TAVR, and then you have the valve, okay? So then you have your gradient. It's like to confirm that there's no, the zero is not good. Yes, I pull the wire a little bit. The sensor has been put very high, so you don't lose the wire anymore. And then you have the aortic pressure in the pigtail, and you check. Most of the time, it's equal. You don't have it, and you just push back, and you have your gradient. If you need to equalize, you equalize, and you push back. So that's the efficient way to do this. If you want to be more purist, okay, yes, if you cross the valve, you have your SavvyWire there. Yes, you can cross the valve with a 7 French catheter, okay, and you have the AO pressure and the sensor, and you have 2 LV pressure. You have the AL1 or the GR4, whatever you use to cross, and you pull back a little bit, you expose the sensor, and then you have both LV and you can zero. There's many ways to do this. What we realize after many cases, you don't need to do this step pre, because it's kind of, you want to keep your flow, you connect, you have the pressure, the grade is 40, the gradient is high anyway, and then you confirm at the end, okay, and we do the same for BAV. We confirm at the end by pulling, okay, to make sure that the zero is not off, and then you advance. We did that with Corval, we did that with Sapien and BAVs. They put the sensor a little bit higher now, so you almost have not to pull a lot. So the first version, you're right, it was more deep in the just before the pigtail. Now it's higher, just for that, and it's easier to equalize. You just have to pull and push. Yeah.
Okay, thank you.
I don't know, Reda, if you have anything to say in your talk now. We answer this, but Reda, if you want to come. So Reda will present his experience also with his first in human, the 60 case that they did, and also how he used hemodynamic.
Thank you, Philippe. Thank you for OpSens also to put that in place. We'll focus. It was more pacing before. Now we'll focus more on the hemodynamic aspect of the wire. So I'm Reda Ibrahim from Montreal Heart Institute. This is my disclosure slide. So, as you know, and concerning hemodynamics, echo tends to overestimate gradient, what we call pressure recovery effect, especially for milder aortic stenosis or just after valve replacement. Invasive measurements are accurate, but takes time to set up and needs wire and pigtail exchange during the procedure. LV pressure is not monitored constantly during a procedure with what we have now. Large amplitude LV pressure create artifact in fluid field lines, and PVL, the paravalvular leaks, are traditionally only accessible via echo, sometimes performed at the end of the procedure. Patient lying down on a table, transthoracic, it's not optimal. We all agree on that. So the SavvyWire is coming with the OptiMonitor. We made the point. It's coming also with an optical connector that you can connect and disconnect anytime during the procedure. It provides an accurate live hemodynamics, including pressures, gradient. It can be the mean gradient, the peak to peak, the max gradient, and the aortic registration index. At least in Canada, it's coming soon in the United States. That's a new information coming now in TAVI procedure, and I think it's going to be important in the future. So hemodynamics, as I said, are always available without exchange at baseline, after potential predilation, during partial deployment for self-expanding valve, after valve release, after potential post-dilation, and at the end of the procedure. So this is the setup. You have your pigtail in the aorta. The pigtail is connected to the arterial line as usual. You have your SavvyWire in the ventricle. You have the sensor here in the ventricle providing live hemodynamic data. You have the pressure within the ventricle during all the procedure, including during the rapid pacing. Philippe was talking about this sensor. The position of that sensor is more proximal to be able to equalize easier with the pressure in the aorta. So the first generation more distal, but after comments to the company, they were able in the second version of this wire to put the sensor more proximal, just to pull back gently the pigtail from the ventricle to obtain the aortic pressure, equalize with your pigtail, but still keeping your position in the ventricle. That step is optional before valve deployment. We are already committed typically for the procedure, but it's often performed after to be sure that we have reliable pressure. So this is the display on the monitor. You have the aortic pressure, the mean, the systolic, and the diastolic pressure. You have the left ventricle pressure. There's two modes. Typically, we are using the left ventricular and diastolic pressure mode because we are more sensitive to that information. And there's three modes for the gradient: mean, peak to peak, and maximal gradient. We are typically using the mean gradient during the procedure. We are lucky enough to use the ARI in Canada and other countries. ARI is the Aortic Registration Index. We are all familiar with the pressure, the gradient, but this is new data coming. I think that's going to be useful in the future. So the ARI is reflecting the end diastolic gradient between the aorta and the ventricle. If the ARI decrease, typically the amount of regurgitation is bigger, and number below 25 typically are associated with increased one-year mortality. So first graph here is the patient with no paravalvular leak, for example, after TAVI. The second one with moderate PVL. So as you see, there's no much distance between the diastolic aortic pressure and the left end diastolic left ventricular pressure. So key for successful measurement of the gradient pre and post TAVI. So your arterial line should be, so the arterial line connected to the pigtail should be well zero. You want to flush well, especially if the line has been moved, reconnect, or if contrast has been injected. You want to ensure that the pigtail is just above the aortic valve. Concerning the SavvyWire, like FFR, we like to equalize at the beginning of procedure, but as I said, it's optional. For us, we like to equalize in the ascending aorta. It's easier with a second generation wire. So we pull back the wire from the ventricle in the ascending aorta. We match the aortic pressure with the pigtail. and then you just push back your wire in the ventricle. You're not losing your position. So we do that typically that at the end of procedure. And at the end of procedures, typically it's not need, but you can confirm that your pressure are still equalized. And concerning the wire position in the valve, you want to pull often this wire to centralize it within the valve. If you don't do that at the beginning of the procedure, you will force the leaflet open. You will potentially minimize the gradient and underestimate the aortic stenosis. And if you don't do that at the end of the procedure, you will potentially create more AR because you will force the leaflet open if your wire is in the outer curve or the aorta. I think we will try to validate that in the future. I think for now, because it's a stiffer wire than the Safari, it's less stiff than the Lunderquist, for example, but it's stiffer than the Safari. It's probably safer if you're using this wire to pull back a bit the wire to centralize it to maximize your evaluation of the hemodynamics. So we were lucky enough to do the first in man, but also the initial 20 humans with Quebec City. Lucky enough also to do the Postmarket registry. So this is the first 60 commercial case after approval in 2022. Montreal Heart Institute, Institut de Cardiologie de Québec with Joseph Rodez and his team, and Vancouver General Hospital with Dr. David Wood and his team. So the objective was a prospective collection of data on safety and performance of the SavvyWire. So a multi-center, observational, all comers coming with TAVI. It was clear that we want to use this wire with all valves available, and typically patient treated with severe symptomatic aortic stenosis. Philippe will present a full presentation tomorrow concerning the demographic and all the data available around the LMR at this meeting. But this is just a summary showing that 60 patient, 3/4 Edwards, 1/4 core valve. We did valve in valve with this, 4 patient, bicuspid valve, 3 patient, alternative access. You just saw the one axillary case that we did was very tortuous porcelain aorta, but most of the cases were carotid. Just to say that the wire has enough support to deliver the valve from any access. And this is the summary of the safety and the efficacy endpoint. So in terms of safety, nothing at all. No guide wire deformation and damage, no LV perforation, no significant loss of capture, no major software malfunction. In terms of efficacy, successful delivery of the TAVI system in all patients, successful LV pacing for all patients. Some issue at the beginning with the monitor with the display that was fixed easily after. Other adverse event, nothing related to the wire. Some major vascular complication I would expect, some bleeding and some new conduction abnormalities. Again, not in relation with the wire per se. We were able also to rate the handling of the wire, mostly in comparison with the Safari. I think the Safari is the dominant wire that we use for TAVI, and so it was compared most often to the Safari, and the overall handling of the SavvyWire was better or similar in 97% of the cases in the Safari. So we are not losing on efficacy with this wire. In terms of pacing efficacy, successful in all cases, as I said. In 3 patients, they had complete AV block. The neat thing with this wire is you can maintain your pacing until you decide what you're going to do. So some patients, they recuperate by themselves, as you know, but for some patients, you want to put an RV pacing lead or even a screwing lead in the RV from the neck. So you have the time to decide what you want to do with this patient, and during that time you have a very safe backup pacing for your patient in complete AV block, and you can remove the delivery system. It's not that the Safari where you want to keep a catheter on your wire. In this case, you can remove the delivery system. You don't, because the wire is insulated, so you can easily pace directly on the wire. So this is the summary of the hemodynamics. Similar result with the balloon expanding valve and the self-expanding valve with the wire. Nothing special to say about that, but reliable and live measurement of the pressure and the gradient. So, in summary of the first 60 patient on the limited market release, the SavvyWire is the first TAVI pressure wire, also the first TAVI wire with pacing indication. Great result on the initial series of patients, zero guide wire related incidents, 100% valve delivery success, 100% pacing success, good hemodynamic workflow success. And keep in mind that it was very early in the experience, so efficient workflow for minimalist TAVI. This is the way to go, I think, in 2023. So let me show you a quick case. This is an 86 years old male, diabetes, dyslipidemia, patient with previous aortic valve replacement. It was a surgical Carpentier-Edwards Paramount 23 millimeter valve. Presented now with the progressive exercise tolerance and shortness of breath. Transthoracic echo at the beginning of 2023 revealed a dysfunctional bioprosthesis, severe stenosis. Valve area was 0.88, mean gradient 49, and moderate regurgitation. Moderate also MR and not too bad LV function. So this is the procedural detail of the TAVI procedure that was performed in March, the right femoral access. Savvy X small wire in the LV for not only valve delivery, but also for valve deployment under rapid pacing, but also for hemodynamics. This is the baseline value of the patient. So the mean gradient is 41, confirming what we measure on echo. But interesting new data coming from this wire is the ARI. So ARI was 6, so very, very low. Revealing, and you can appreciate that, I think, at the end of the dye study here between your aortic curve and your LV curve, that is probably a more significant aortic regurgitation that you maybe think from the echo. So severe AR, severe aortic stenosis. Here we deliver a core valve, Evolute FX 26 millimeter valve, good support to turn around in the aorta, and then rapid pacing for precise positioning of the core valve within the surgical valve. You see that here. So again, pacing with your wire here. Sensor is here in the ventricle. During all the time, you have your pressure in the LV during the rapid pacing. You know what's going on, and then after you relieve the valve, we used to think that at 80% the core valve is functional. We know that it's not true anymore with the SavvyWire. So at 80% deployment, there's still a gradient, a significant gradient across the aortic valve. And this is the just after valve implantation. Now your gradient is down to 25. The ARI is better, but it's not perfect. Typically, we want a value above 30. It's 24 here. So, I mean, it's not an optimal result at this point. So without exchange at this point, you can go back with a balloon to post-dilate. And we decide to post-dilate with a non-compliant through balloon, 22 millimeter, and crack the bioprosthesis surgical valve in place, just to obtain that beautiful result that we want. So after post-dilation and fracking or cracking of the surgical valve, the mean gradient is now 9 and the ARI is 30. And as I said, we want to be above 25, 30 in case like this. So I think this is a nice example that before Savvy, you would potentially say, oh, am I going to do an exchange because I want to put my pigtail back, measure my gradient, decide if I want to post-dilate. I mean, in this case, no exchange, live measurements, and then you do what you do, and then you can appreciate right away your end result. So next day, transthoracic echo confirmed the gradient that we measure with the Savvy at the end of the procedure, 9 millimeter mercury, same gradient, no AR, mild MR, so it was improved, and a bit slighter, better ejection fraction. So in summary, I think SavvyWire reduced device. It replaced traditional TAVI guide wire. It replaced, replace one transducer, replace venous access gate, RV pacing wire, potential closure device for vein. SavvyWire also support case efficiency because it reduces transducer setup time, eliminates venous access, and minimizes device exchange for pressure reading. SavvyWire also enhances procedural predictability because we have a continuous and constant measurement of the hemodynamics, and it minimizes RV pacing complication. I just want to go back just to finish this talk because I want to focus also on future. I think this is the present now for SavvyWire, but there's a clear, I think, bright future in my mind. And this is, I think, the future, I think, for SavvyWire. I think it's going to be a more widespread use for aortic stenosis. Some centers are still doing a significant amount of balloon aortic valvuloplasty. I think it's definitely helpful. Put your wire in, evaluate your gradient, and you can dilate as much as you want with, say, increase of your balloon size. If you plan to pre-dilate also during TAVI, it's very useful. For example, for bicuspid valve, critical aortic stenosis, or for some self-expanding valve, as you know, accurate neo, for example, there's always a pre-dilation. If you want to post-dilate, in your potentially post-dilating procedure, it's also useful. Valve-in-valve procedure, for example, especially if you want to crack the surgical valve. I think it's going to be useful also to assess and to treat moderate aortic stenosis, and to treat and to follow this potential dysfunctional bioprosthesis that follow up, including TAVI valve. As you know, there's two trials on moderate aortic stenosis, or the TAVR expand for Medtronic, and I think it's going to be useful potentially to evaluate better some patient with moderate stenosis, because we will come with some functional evaluation of the aortic valve in the future. I think with this wire, we will be able to evaluate the FFR of the aortic valve. So you will have the wire in place. You can stress the patient, give dobutamine, and see what's going on with your pressure in the LV and the aorta, and assess the resistance of the aortic valve. I think it's going to be, with the SavvyWire, the FFR of the aortic valve. And I think if you want to think also out of the box, you will potentially use this wire in other locations like mitral and tricuspid. I'm sharing a recent tricuspid case that we did. So valve-in-valve, it was a severely stenotic tricuspid bioprosthesis, Kaplan-Meier Edwards number 29. Mean gradient on echo was 17. On the SavvyWire was 10. So in this case, an Edwards S3 29mm valve was easily advanced from the IVC on the SavvyWire, placed in the RV. Rapid pacing on this wire, deployment on the rapid pacing, excellent final result. So the gradient was down to 4 at the end of the procedure. So I think definitely minimizing the amount of tools, and useful to rapid pace, for example, to deliver a valve on the right side. Thank you very much for your attention.
All right, we are going to have a little time for discussion. Please feel free to go to the microphone and to ask your question. I have to say that your last case of valve-in-valve was very, very good, because I think if there's one place people want to start to use this wire, actually I think there's two places. First is the valve-in-valve, where there's a decision-making about am I done, should I crack, and this efficiency of having the device still in place, the wire in place, and minimizing the pass in front of the brain. You know, there's a price to pay to all those maneuver that we do, and you always want to spend less time in patient and actually minimize your manipulation. So this case was great. Valve-in-valve is so great because you just pull the device and then you assess, and when you crack, you assess again. The ARE actually was fantastic, showcase of like you reduce the AI, and I think in the future would be great. I like to use this device, this SavvyWire, for BAV also. I think when you have a BAV and you take a sheet, you can equalize on the side part of the sheet. You have your wire in, and you have your gradient, your balloon. You just pull back a little bit the balloon, and you have your gradient if you want to put more CC in the balloon and do it more. So this, I think, is very becoming an efficient BAV, an efficient valve-in-valve with no LV, no RV pacing. So I think this case embodies why this is a good solution.
I think you made a great point. I mean, the study on distal protection device are not as positive as we were hoping. So, I mean, if we are not using a filter in the carotid, we should do everything that is possible to minimize the amount of exchange. So, I mean, if it's not positive here, we should find ways to keep the safety of this procedure.
I fully agree.
The other one, I think I totally agree. Those are two places where this wire really shines. The last one is very heavily calcified valves where you're worried about PVL and your area, your index of regurgitation is, you can get it immediately. So it's nice to see that right away.
And I think it's good for self-expanding valves sometimes to go with with a maybe underfilled balloon. So you can go with instead to go nominal, you can go potentially smaller with the balloon and evaluate your hemodynamics. And if you are not happy, you want to post-dilate, you can still add 1 or 2 more cc in your balloon and post-dilate your Edwards valve, for example, without removing your balloon from the patient. So you just pull back your balloon in the descending order, you evaluate the hemodynamics, and if you want to post-dilate, you go back.
Yeah. So I think as we go into the younger and younger patient, TAV and TAV, I think it's coming. All the leaflet modification technique are coming, shortcut leaflets, all those removing wire. You need a way to see right away what is the pressure, what is the ARI. So I think we're preparing the future with this tool, and we're enabling actually a lot of cool device to really be safer and more efficient, and to guide us actually not only with TEE and TTE, but also with true pressure inside, which I think for the next 10 years we're going to see a flurry of devices come try to remove leaflets, cut leaflets, shockwave the valve, and I think that you need hemodynamics to follow that. One thing I want to discuss is the case of when you have, for example, a patient with a right bundle branch block, large left bundle, 160 QRS. Usually we put a neckline and we put a TVP, not because we want to pace with the pacement, the RV pacing, more for management after the case, for the 24, 48 hours you want to observe. So in those cases, what we've been doing is I put a sheet, okay? If it's a left bundle, don't put the pacemaker, but I put a sheet because, you don't want to have to stick the patient when you complete AV block. For a right bundle, I put a sheet and a pacemaker. And I use a SavvyWire in those cases. Like you mentioned, most of the time when you have a complete AV block, it's kind of subside by itself in 2-3 minutes. Most of the time, it's like sometimes you cross the valve and boom, and the septum is irritated and inflamed.
Yeah, sometimes it's just crossing, or just when you put your wire, it's not even the valve.
Yeah.
Stunning or whatever we call it.
It's like in concussion, it's a concussion of the septum, and then the septum wake up. But so it's very rare that you have a sustained complete AV block. But for those situations, first, if you have a complete AV block, you pace, you don't panic, you just pace on the wire, and then you float your pacemaker. In a right bundle, I prefer to put right away a right RV pacing in the neck, but I still use the SavvyWire for the pressure and the pacing because I believe it's a little bit more reliable. So in this specific situation, you just need to be ready. Okay, you don't go blind LV pace everyone with no safety net, because it's not about only the procedure; it's also about the management on the next day. I want to have, a neckline, and I want to have some backup plan. What is your strategy with those left bundle and right bundle?
Pretty much mimic exactly what you said. The one thing that it would be nice here, though, is, it's not a huge deal to do all that. It does add some time, a little bit of cost. Patients don't like having this neckline in their neck the next day. And so if you could just sort of pace with the SavvyWire for a couple of minutes, and then if it comes back, you can take this out safely, and it saves the patient a lot of discomfort. So.
Yeah. And one thing, Reda, what you said is I'm becoming obsessed with, we still do a lot of TE and TT in the room. And every time I always want to remove the RV pacing under direct visualization. Yeah. Because a lot of time, not a lot of time.
We all experience this. I mean, you remove the lead and then the hole is there in the RV.
So it's not trivial the amount of time when you remove, you expose the tamponade. And I remember a case Friday night, 7 p.m. I always do a second round at night just to say bye to the patient and just to make sure they're okay. and you know, manage angry patient. But sometimes, but I always go back, and this patient says, oh, let's remove the pacemaker, because you know, then exactly the patient, I have my neck, and I remove it right away. She became vagal, pale, and massive tamponade. So I think sometimes we do a lot of manipulation, but the RV pacing are not trivial. And what we discover by using the SavvyWire, we're obsessed with diffusion, and we realized that the RV pacing was probably the culprit of more disaster that we thought. Yeah.
Disaster are rare, but it happens. I mean, we had recently a case with a patient with a suicidal left ventricle, so very small ventricle, a lot of hypertrophy, and it was clear for the patient that the treatment was to give fluid based on what we saw on the pressure in the ventricle. So you need to, I mean, in some case, not a huge amount of case, it will change your management.
Any question from the audience, or? Yep. On the cost, yeah. So one thing I can say for sure, it's less expensive than Sentinel. It's not $3,500. It's less expensive than the Manta. It's not $1,000. You know, I think right now it's between, you know, $800 roughly. And I'm sure you can negotiate hard with your absence. So I think when you look at the cost, you know, of RV pacer, venous access, the time you save, and I would say the advantage it gives you for managing the patient, I think it's all swallowing the cost. You know, we're not, when you look at the CTO business, these guys using like 40 wire a case, it's $8,000 of wire just to cross. They're using, so I think if you have, you know, what will be the price you're willing to pay for such devices? I think it would be debatable from geography, but I think, you know, people are willing to pay $3,500 to protect the brain when there's no evidence, or they're willing to use a Manta because apparently it saves 2 minutes on the closure device time. So I think you decide to pick what you want to invest. There's always a rationale, but I believe the cost will be way offset by how quick the case will be, the less bleeding on the right side of the stick of the vein. And when you look at the price of all that, it's probably a $200 difference. So I didn't have any issue with my administration when I went to say, listen, guys, I want to use this. I didn't use Sentinel for like 6 years, so I save you X million dollars. They're okay. I mean, you just need to build a rationale about efficiency, safety, efficacy. And I think you can negotiate with absence whatever the price will be, but I don't know what you feel, guys.
So, in our case, we replaced the RV pacing lead with this. We replaced the Safari because you're using this wire instead of the Safari. We save also the perclose that we typically put on the vein. So, I mean, it seems benign. It seems that perclose, it's nothing, but it's adding cost also. So if you see what you were doing and what you're replacing with this, I mean, at the end, it's pretty similar.
I think it's like all the other device. You know, if you use 1,000 a year, I'm sure they would be happy to make a very pretty price for you. If you use 5 a year, I mean, I'm sure you're gonna have a list price. But it's go with the volume, I believe. But for me, you know, I'm not looking at saving $200 per case, especially when the reimbursement of TAVI with high-risk patient, for example, is like, depending on the geography, 10,000, 15,000. So I think there's room for that.
Good morning. Thank you. Great presentation, interesting device. I'm sorry I step out for a second. You may have answered this question. If somebody develops a complete heart block, and you said it would be stable while you put your temporary, but obviously you have the alligator in the back and you have the delivery system. So there will be a time where you will have to, unless you leave the delivery system in the wire, there'll be a time where you have to walk the delivery system out and remove the alligator in the back. What do you do in that gap? It should be a few seconds. And the other thing is the manipulation, making sure that the contact is still in the V, you know, with the wire while you're taking this other out. So just walk us through the technical aspect.
There's a specific zone to put your alligator clamp on the wire, but you can paste on anywhere on this wire with the clamp. So if you want to remove, let's say it's an Edwards valve, you put you want to remove your delivery system, you can put your alligator clamp at the end of the wire, and it's still pacing. even if it's not in the zone that there's no cover, there's not covered by the insulation. So you put the clamp at the end of the wire, still pacing. You remove safely your delivery catheter, and then you can just switch the clamp.
the
And
front.
if you're not pacing, it's just for few seconds.
I see. Thank you.
That's what we do. But again, I think I will reinforce the case that for left bundle, right bundle, and sometimes a lot of oversized with massive LVOT, calcium or MAC, I use a neckline, okay? So I'm ready. So, but I agree with the comments. If you pace on the distal part, it's a long way. You can bring a delivery system in the sheet in the distal aorta, not to leave it in front of the brain. That's the key. So you start to unsheath, and a lot of people like to pace on the distal ends, okay, which is fine. I like in front of me because I don't say pacer off anymore. I just remove the alligator key, so I control everything. But so yeah, that's the way to do this. Yeah. Any other question? All right, so if not, we're gonna close the session. Thank you so much for coming this morning. Thanks again for the panelists and the speaker and the OpSens for making this thing happen.